speaker is going to deliver talk on primary hyperaldosteronism. For physician needs to know, I welcome Dr. Nilesh Detroja sir for a next talk.
So let's discuss and let's see whether it is common or uncommon. So how many of you have seen more than 2 cases of confirmed primary hyperaldo in your practice so far? More than 2 cases. Anybody? One person? Anyone more than 5? So this is common or uncommon? So, thank you. So classically it was described by Kohn as a triad of hypertension, hypokalemia and adrenal adenoma, and this triad is very uncommon in primary hyperaldo. We don't see all these features most of the times. So primarily it is elevation of aldosterone and suppression of renin, which we call as primary hyperaldosteronism, which will lead to excessive activation of mineralocorticoid receptor, followed by vicious cycle of volume expansion, hypertension, cardiovascular and kidney disease that is independent of elevation of blood pressure. So suggesting the direct effect of aldosterone at the level of tissue and organs. So this is the physiology. Angiotensinogen will be converted into angiotensin 1, 2, and finally that will stimulate adrenal and produce aldosterone. While in hyperaldo, there will be autonomous production of aldosterone from the adrenal gland, which will lead to the negative feedback. Renin will be suppressed, so ultimately leading to low renin and high aldosterone. Aldosterone, in addition to the effect that leads to hypertension like vasoconstriction and increase in plasma volume, it has very significant effect in terms of inflammation and fibrosis, and that is the reason of increase in risk of cardiovascular and kidney disease, that is in excess of elevation of blood pressure. So when to suspect secondary hypertension? Any patient with having severe hypertension, resistant hypertension, young hypertension, malignant hypertension, hypertension with hypokalemia, hypertension with presence of adrenal adenoma and presence of end organ damage in young patient with hypertension. So these are the conditions where you should always look for the secondary causes of hypertension. So if you talk about the hypertension with low potassium, it can be high renin, high aldosterone, which is because of renal artery stenosis. It can be low renin and low aldo, primarily because of Cushing's and other uncommon endocrine disorders, or it can be because of primary hyperaldo, that is low renin and high aldo, leading to hypertension with hypokalemia. So primary aldosteronism is the most common cause of hypokalemia with hypertension, and it is the most common cause of secondary hypertension. It may be because of there are several varieties anatomically of this entity. It can be single adenoma from adrenal gland. It can be bilateral adrenal hyperplasia. It can be unilateral adrenal hyperplasia, or it can be diffuse multiple foci of autonomous aldosterone production, and that is the most common variety. Genetic causes I am not going into the detail. So primary aldo is very common. It is the commonest cause of low renin hypertension, and whenever you see low renin and hypertension, it is PA until proven otherwise. So it is very common, but unfortunately we are not picking up. Probably it will be there in your clinic every week. So you must have seen so many patients of primary hyperaldo so far in your practice, but unfortunately we are not diagnosing and not treating it properly. This is the older data of prevalence of this entity, ranging from around 6 to 13 patients in various studies from different part of world. But this is the current most conservative estimation. So in any patient with resistant hypertension, around 20 to 30, 25 to 30% will have primary hyperaldo. Hypertension with hypokalemia, more than 30%. Even stage 1 and 2 hypertension, more than 15 to 20% of patients will have this entity. And in pre-hypertensive patients also, there may be around 10% of patients who are having mild entity of primary hyperaldo. So even if you take the classical indication of screening, that is resistant hypertension and hypertension with hypokalemia, still hardly 1 to 2% of patients are being screened for this disorder. And unfortunately, that is true even in the best setting of healthcare in the world, in the US and Canada, hardly 2 to 3% of patients with hypertension are being screened for this entity. So why? What is the reason for this? Why we are not screening for primary hyperaldo? Maybe because we don't know that it is really that common and it is really that important to screen and treat. Maybe we don't know how to screen because it is having complex protocol of testing. Or maybe in some patients, this is the reason, the cost. Plasma renin activity is around 5,000, aldo is around 2,000, so altogether more than 7,000 cost. So at least I think these two things are not that difficult, and we'll make sure that you all understand these two and start screening at least in few patients who can afford this testing. So the first and foremost thing, till date we knew that you required to stop these medicines for 2 weeks, 4 weeks, 6 weeks. So that is not required. Only you have to stop spironolactone or eplerenone if patient is on that medicine. Otherwise, don't stop any medicine. You can straight away go for renin and aldo morning sample. That's it. So it's not complex. At least the initial part of screening is easy. This is the cutoff. Plasma renin activity should be less than 1 nanogram per ml per hour. Aldosterone should be more than 10. Ratio should be more than 10 to 20. So this is the latest cutoff guidelines. Probably we are going to have even lower cutoff in next guideline, which is going to come in next 2 or 3 years, because of lots of newer data and evidences which is suggesting it's very common. So any aldosterone production when renin is low, it's significant. So there is no definite lower limit of aldo that confidently excludes primary hyperaldo, although it is currently more than 10, but you can have primary hyperaldo at the level of aldo of 5, 7, 8. So we'll see that also in next few slides. So cutoffs are going down. Earlier it was 20, 15, 10, and probably it's going to come below 10. Why it is so? Basically, it's a spectrum of disease. It's not a single entity. So it starts from the small foci of hyperplastic tissue producing aldosterone in the adrenal. It will increase in the cluster gradually. Ultimately, it will produce single adenoma, which will be primary hyperaldo, a single site disease. But you can see it's there. Even milder disease, the prevalence is very common. It's very high. But severe disease, that is the classical adenoma, is not that common. So as you go from here to here, the severity of disease will increase, but prevalence will go down. So we have more milder disease than severe disease. Now these all our patients are confirmed and treated primary hyperaldo. You can see if you take the cutoff of aldo around 10 or 12, half of the patients you will miss. Half of the patient had aldo level of 10, half had more than 10. So this cutoff is purely arbitrary. Again, in this slide, you can see all the patients had confirmed primary hyperaldo. These blue bars are patients with severe disease who are having aldosterone producing adenoma, and this lighter blue are having hyperplastic or bilateral disease. So you can see this part here in this picture. these all patient had aldo level of less than 10. So even if it is less than 10, you can have primary hyperaldo, and sometimes you can see this blue bar also. They can still have adenoma also even with this low level of aldosterone. So once you have done the initial testing, that is aldo and renin, and if it is suggestive of disease, next comes the confirmatory test. So this was again the major headache to do this test. There are so many tests available like oral sodium loading test, IV saline infusion test, fludrocortisone suppression test, and 6 or 7 more tests which is not required. So this so-called confirmatory test, they are not validated, they are not calibrated, they are labor and resource intensive, they contribute to false negative case detection, so they are not necessary in the vast majority of cases. So you forget about the confirmatory test. Now, there are few pointers which may help in differentiating between the hyperplasia versus adenoma, that is milder disease versus severe disease. Like patients with aldosterone producing adenoma, they'll have comparatively more severe variety of disease, more severe hypertension, more chance of hypokalemia, higher level of aldo more than 25. They are comparatively younger. So you can get some clues from the history and the level of aldo, but it's not always true. Once you have done the initial testing, the next step is to go for imaging. So we have several imaging options like CT, MRI, PET scan. So this is how you will have adenoma look like in the CT scan. Now again, there are some issues here also. So many investigators suggested that if you have hypokalemia, if you have significantly high aldo with the ratio more than 50, and if you have single tumor size more than 1 centimeter, you can straight away go for the surgery without doing additional test. But there are so many studies where they suggest that almost 1/3 of patients, if you directly go for surgery with this kind of profile, they will not be treated because they will have bilateral disease. If you are going for unilateral adrenalectomy, still disease will persist in almost 1/3 of patients. At the same time, absence of mass does not exclude aldosterone adenoma, producing adenoma, because it may be very small, you may not be able to detect in CT scan or PET scan. Even in those patients who are having bilateral lesion, that is again confusing, because in that bilateral lesion, one may be just incidentaloma or non-functioning adenoma, and the second may be aldosterone producing adenoma. So here also the scan is not going to help. So the accuracy of CT is just 50% in deciding whether this patient is having unilateral disease or bilateral disease. So it's like tossing the coin. Again, confusion will persist. So what to do next? So next test, that is adrenal venous sampling or AVS, which is really useful in large number of patients where you don't have the clue whether to go for surgery or to go for medical management. Unfortunately, it's a difficult procedure. Few radiologists only are doing, and fortunately, we have one person in Rajkot in Wokar Hospital, that is Dr. Vikas Jain. He's doing it wonderfully. So if you go by the guidelines, only few patients where nodule is clearly more than 1 centimeter in one adrenal, second adrenal is normal, and young patient that is less than 35 years, straight away you can go for the unilateral laparoscopic surgery. And in some patients where scan is normal, there is less possibility of having aldosterone producing adenoma, you can straight away go for the medical management in terms of spironolactone. But remaining large number of patients, you will require adrenal venous sampling. So adrenal venous sampling is gold standard to differentiate whether it is unilateral disease or bilateral. This is how samples of aldosterone and cortisol are being taken from the right adrenal, from the left, and from the IVC. Right adrenal is little difficult to cannulate because of this angle. So that is the reason it's not possible for everyone to do this procedure. This is just an example of successful AVS. So aldosterone was taken from the right side, cortisol, left side both the samples, and IVC, aldo as well as cortisol. So the next step is you have to take the ratio of aldosterone to cortisol. So this is the ratio, and you can see here right and left there is a lateralization. This should be more than 4 times. So here it is 6.2. So this patient is having unilateral disease, that is the right adrenal is the source of aldosterone production. So because of the complexity of procedure, we have to find out some other options for the diagnosis, and we have some options at least in some patients, like various kind of PET scan, and in that this is the one which is now newly available, and it is very helpful at least in patients who are having single adenoma of more than 1 centimeter size. So to confirm that, you can have 68 gallium pentoxifer scan, PET scan, that will help in differentiating whether it is aldosterone producing adenoma or not. So let's take one case example. 64-year-old male with resistant hypertension on 4 medicines with full dose, still BP is very high, already CKD stage 4, history of cardiovascular disease, spontaneous hypokalemia in spite of having CKD, very low renin, very high aldo, C3 adrenal is showing left side lesion, AVS is not possible here because of CKD. So this patient underwent 68 gallium pentoxifer scan, and which was suggestive of adenoma on left side. So this is the CT, left adenoma, right is normal, and this is the pentoxifer scan. You can see the uptake on this side. So this patient underwent laparoscopic left adrenalectomy. Post-surgery BP was very well controlled with just 2 medicines. So this was the case of Dr. Sagar. He discussed earlier in our APR format also. Coming to the treatment part. So we all know now treating blood pressure, controlling blood pressure alone is not sufficient because of the direct effect of aldo at the cellular level in the heart and kidney, which is independent of blood pressure. It is leading to the fibrosis and poor outcome in terms of cardiovascular and kidney disease. So we need to have surgical treatment whenever possible. So this is the very good slide suggesting the importance of surgery. So there are 4 group of patients. Here this patient is having confirmed adrenal adenoma. They all underwent unilateral adrenalectomy and treated. This is the patient with essential hypertension treated medically. And these 2 groups are patients with bilateral disease where surgery is not possible. They were treated medically. In one group, even after treatment, the renin level was persistently suppressed. That means the basic physiology was not corrected, and here with medical management the renin was increased, so there was a restoration of physiology. But you can see the difference in the outcome. The best outcome will be with the surgery, even better than essential hypertension. Those patients who are treated medically and you are able to increase the renin level, it is almost as good as treating essential hypertension. But when your renin still remains suppressed, the outcome is not good. So this is very important to find out the lesion and if possible treat surgically. If not, then you have the option of medical management. Surgery is not that difficult. Laparoscopic surgery with good hand, it's quite easy. So after surgery, within few days, the dose of antihypertensive medicines will come down, and the full impact will be at around 3 months, where the requirement of medicines will go down significantly. In the medical management, we have several options available. The goal of medical management is to normalize blood pressure, to increase the potassium level, and to increase the renin level whenever possible, in addition to the lifestyle modification. So we have very cheap medicines available since many years, that is spironolactone. It should be started with the dose of 25 to 50 milligram and increase according to the requirement. You can give up to 400 milligram if patient can tolerate. Goal is to keep blood pressure in the normal range and to keep potassium in the higher normal range. Hypokalemia will respond immediately with the treatment. Hypertension response will take few weeks with this medicine. It has some side effects because of the antagonism of androgen receptor. In male, it can cause gynecomastia, erectile dysfunction, and loss of libido, while in female, because of agonism of progesterone receptor, it can lead to menstrual irregularities. So whenever you have the issues of side effects, we have the second choice, that is eplerenone, although it is not as potent as spironolactone. So it should be considered in those patients who are having side effects with spironolactone. This is the second option available. So you try to achieve not only normalization of blood pressure, but if possible, if patient can tolerate the higher dose, you go with the higher dose and try to achieve renin level of more than 1 if possible. So to summarize, primary hyperaldosteronism, which is very, very common, it's not uncommon. Most of the low renin hypertension is primary hyperaldo, unless proved otherwise. All hypertensive patients ideally should be screened for primary hyperaldo, and most patients with primary hyperaldo are normokalemic, so don't wait for potassium to go down. Immediate diagnosis and treatment is useful to particularly prevent the long-term comorbidities, morbidity and mortality. Surgical treatment is definitely the treatment of choice whenever you are able to locate the adenoma. In those patients where you have bilateral disease or you are not able to go with the procedures like AVAs, you can go with the medical management. It's available at very cheap rate. And of course, you have to find out the case. For that, you have to do the test. So renin and aldo, at least start doing in patients with resistant hypertension, those who are already on 3-4 medicines. That will be definitely helpful. And even if you are not doing that, start using spironolactone in this kind of patients, even if patient is not able to do the test of 7,000 rupees. So that will be also helpful. So that was all from my side. Thank you very much.